Welcome to a special panel of the last day of the conference. The special panel here is entitled The Future of Disability Services Toward New Models. We have three speakers from different parts of the world, from Canada, from Australia, and the UK. And hopefully together we'll have a nice discussion about how we can better support children with disabilities through reorganizing or restructuring or repackaging the health and rehabilitation services that we provide for those children and youth and young adults, and move forward toward more efficient, inclusive, integrative, and accessible services. So let me introduce our speakers. We have three speakers, as I mentioned. Professor Hannah Kuper is a professor of epidemiology and one of the directors of the International Center for Evidence in Disability at the London School of Hygiene and Tropical Medicine. She is also one of the founders of the Mission Billion Initiative, which focuses on improving access to healthcare for people with disabilities. So welcome, Hannah. We also have Professor Christine Imms with us today, who is Apex Australian Foundation Chair for Neurodevelopmental and Disability at the University of Melbourne. She's, of course, from Australia. As an occupational therapist, Christine has had long-standing clinical and research interest in optimizing participation outcomes for those with child-onset neurodisability. Today, she will present briefly on the Australian National Disability Insurance Scheme as a policy approach to changing the landscape in disability service access and provision. Welcome, Christine. And our last speaker of this panel is Julia Hans, who is an incoming resident physician in physical medicine and rehabilitation. Julia is a disabled athlete who currently holds Canadian records in para-athletes. She has research interest in participation-based rehabilitation approaches and is passionate about improving the lives of people with disabilities through sports. So we can definitely start. Hear some new innovative opinions and approaches. So Hannah Kuper, I invite you to start whenever you're ready.
Well, thank you very much for the introduction, and thank you everybody who has come to join the session. I'm giving the introduction where I will frame some of the issues, and I think the other speakers will go into greater depth on specifics. And I'm going to be talking about health systems inclusive of children with disabilities, why and how. And I'm going to start by introducing this baby who is now a child, is a lovely boy, much wanted boy, born in Brazil, but affected by congenital Zika syndrome and microcephaly. And so because of his various conditions, he's going to have specific healthcare needs. So he needs routine healthcare services like all children. He needs vaccinations. He needs to have bed nets where they're needed and so on. He also may, on average, have worse health than other children. So if he's a wheelchair user, he may be more vulnerable to respiratory diseases. He may be more vulnerable to malnutrition if he has feeding difficulties. And as a result of that, he may therefore need more general healthcare services than other children and his other friends. And he may also benefit from specialist or rehabilitation services. So I've already mentioned wheelchairs, but other kinds of physiotherapy, orthopedic surgery, eye care specialists, and so on. So on average, children with disabilities have a greater need for healthcare services. But they often face challenges in accessing these services. And we can think about that happening across the healthcare seeking journey. So it first starts in the home, where there is a recognition that the child needs healthcare services and a decision is made to put the time and the money into going to those services. There may be difficulties in accessing the services if the transport is not available or services are too far away. The services themselves may be unaffordable or inaccessible, physically inaccessible for children with disabilities. And the healthcare providers may not have the knowledge or skills or resources to provide services for children with disabilities. For instance, they may not know how to communicate with children with intellectual impairments or have adapted equipment to be able to offer services for children who are wheelchair users. Now, those challenges are the things that we can observe, but they come from somewhere. They don't come out of nowhere. And they also result in worse outcomes for the child. So because of these problems with lack of healthcare services and difficulties, children with disabilities on average are more likely to experience malnutrition, severe diarrhea, serious illness, and they have much higher mortality rates than children without disabilities. So the greater need coupled with the lack of services means worse outcomes in terms of health on average for children with disabilities. Now, this is a huge problem. It's a problem if we look from a development perspective, because we will fail to reach development's targets such as good health and well-being. It obviously matters to children and their families if the child does not have good health, and that health is very important for other things like going to school and having a job and participating. Children with disabilities have the right to healthcare. So if they are not able to access services, that is a violation of their rights. And if we think about how to improve healthcare services for children with disabilities, like making things affordable and physically accessible, and making sure that healthcare providers are trained to communicate with people with a range of abilities, that will improve healthcare services for all. And if a child doesn't have good health, he or she may not be able to go to school and so on, and that will be a violation of other rights and also make it more difficult to achieve other development targets. So these kinds of challenges to accessing healthcare services, I've said these are the things we observe and they come from somewhere. And so why are these things happening? It happens because of systems level failures. For instance, that there is a lack of data and evidence on the gaps that children with disabilities are experiencing. There's a lack of legislation and policy to protect the right to healthcare for children with disabilities, or where that legislation and policy is in place, it's not monitored or enforced. There is a lack of financing and funding to support services for children with disabilities, and there's often a lack of leadership and management of these issues. And because of those systems level failures, we get the observable challenges to accessing healthcare services like unaffordability. And so I've been working with the Missing Billion framework, where we've been trying to formalize this into a way of thinking about an inclusive health system framework. So how we can flip around these barriers to see what is needed to make sure services are accessible. So there's the systems level things like having governance and leadership and money and data and evidence. In terms of service delivery, from the demand side, from the child with disability and the family, there needs to be autonomy and awareness and affordability of services. And from the supply side, so from the healthcare system, there needs to be adequate human resources, there needs to be facilities, and there needs to be specialist services and assistive technology. And we believe that if we have these things in place, there will be better effective service coverage for children with disabilities and therefore better outcomes. So if we think about this kind of framework, we can start to explore what can be done. So for different countries, we can think about must-haves. So in terms of governance, are there laws and policies in place? For leadership, is disability or childhood disability clearly represented in the Ministry of Health? For health financing, is health financing insurance available? And is routine data available to show the healthcare needs of children with disabilities? From the demand side, are people with disabilities able to make their own decisions? Can they afford healthcare access? And from the healthcare provider side, is the healthcare workforce knowledgeable about disability? Is the infrastructure accessible? And are quality services available? And with these kinds of structures in place, if we probe them and explore them and then try to improve them where there are gaps, then we will improve healthcare access. And that means that children like this lovely boy born in Brazil will be able to have good access to healthcare, which is his right and will allow him to lead a good life. Thank you very much for your time and attention. And I believe that the fellow speakers will probe some of these issues in greater detail.
Thank you so much, Hannah. We will continue with the next speaker, Professor Christine Imms. Please go ahead.
Thank you, Dana. I'm just waiting for my screen share.
Okay.
Double checking that you can see. All good. Thank you so much. So I'm going to talk about Australia's National Disability Insurance Scheme and a little bit about its relationship to participation outcomes. So the National Disability Insurance Scheme is a national scheme to provide disability funding to individuals themselves so that they actually can exercise choice and control over purchasing the reasonable and necessary supports that they require to enable them to enjoy a normal life, to be involved in their communities and to have a job. It's a disability scheme, so it is designed specifically for people with permanent and significant disability, and that could be intellectual, physical, sensory, cognitive, or psychosocial disability. Because it's an insurance scheme, that means it's a demand-driven system, and it is funded by governments redirecting their disability spending, but also by a Medicare levy that is placed on our taxable income across the country. It's called a scheme, because it's not a welfare system. It's actually about providing reasonable and necessary supports so that skills and independence can improve over time. So it's future focused. So how did it happen? So prior to our National Disability Insurance Scheme, Australian disability services were provided via Commonwealth and state-based agreements and operated really what I would call as a welfare system. So there were disability pensions, there was block funding provided by government to organisations who then decided what were the services that were going to be provided for people with a disability. Back in the first 10 years of the 2000s, there were some concerns about the sustainability of that system and formal Senate and productivity reviews that really resulted in a decision that the current system was expensive, inefficient, not equitable, and not really sustainable over the long term. So what happened after those broad-based evaluations of our system was that actually there were some proposals around how can we get closer to a human rights perspective here and actually meet our obligations. And that really then led to the development of a large number of very good and powerful advocacy groups who really talked about giving voice and giving choice and control over the selection of services. By 2013, there was a passing of the National Disability Insurance Scheme Act and the formulation of an agency to implement and deliver the scheme. The next 3 years, between 2013 and 16, saw the sort of implementation of trial sites, different states, different regions, different age groups, tackling how to solve the implementation of such a large-based idea. The next 4 years saw a full scheme rollout, so you can see we've only just got to all of Australia covered. And then in the last sort of 12 to 18 months, we've also had a formal review, the Tune review of the implementation, and there are ongoing consultations and feedback loops around how it's actually going. That's been the sort of time frame. Well, how does it work for an individual? So the first thing is you think, oh, this might be for me. So you find out whether you're eligible. You're eligible if you're aged between 7 and 65 years, because after that it goes into our aged care system. Under 7-year-olds are also eligible, but they go through a slightly different system because we're really keen that they don't miss out on early intervention. You have to be an Australian citizen or resident. You need to have a permanent and significant disability and also require equipment or support for that. Okay, so you've ticked the eligibility box. Then you have to go through a formal application process where evidence of disability and impact is required. I'd just like to point out here that the evidences sought here are not, they do include diagnosis, but really it's about the impact on function. So what are your mobility needs, communication needs, self-management needs? And I've just put in a couple of the example measures that are used, that can be used to provide evidence about your need from a functional perspective. And they're things like the Paediatric Evaluation of Disability for Children, or the HUDAS, which is a disability assessment scale. And if you have cerebral palsy, then it's the gross motor function classification and the MACS and the communication function classification systems that can build evidence about your need. Okay, so you're eligible, you've applied, you've been deemed that there's a package for you that's been determined, and now you can start to plan what you're going to use your package for, so your funds. So you get to set goals and create a plan. And the sort of questions that the NDIS suggests that you ask is that, to be happy and live a good life, what do you see? What will that look like for you? And what needs to change in your setup to actually enable that? And the goals that are set against which funds will be spent are participation focused. And I've put one example up on the slide for you. I want to learn to use public transport by myself so I can go to the library without needing mum to drive me. So participation focused goals, and then really addressing what are the day-to-day needs and supports, equipment and services that enable you to reach those goals. Got a plan, you've got some funds, now you have to figure out how you're going to manage those. You can either be self-managed, fully self-managed, so the funds are there and you manage how they get distributed and used, or you can have plans support, so that means you get some partial support with that planning, or you can have the National Disability Insurance Agency manage the funds for you. When you go to seek services, you do have to use a registered provider if you're using your plans, your funding from your plan. After 12 months, you go back, you review your goals, set new goals, and move forward. So how's it going? So from the 2020 annual report, I've just pulled a couple of bits of information out for you. At this point, we have around 400,000 Australians on the National Disability Insurance Scheme. Around 16% of those are children, and an average cost per year is about 50,000 Australian dollars. You can see it's big dollars. I thought I also would pull from the annual report for you the sort of questions and the sort of data that's been collected around the use of the NDIS and the outcomes following that. So for the small children, which is the first things in the red box here, asking questions about whether or not specialist services are used, but more importantly, are those services helping your child gain skills for everyday participation? And if you are participating in the community, do you feel welcomed in your community settings? If we look at the kind of data that's being collected at the older age groups, so the 15 to 24-year-olds, I'm making more decisions for myself than I was 2 years ago. I'm actively involved in a community group. I'm currently working in a paid job. So I think it's really important just to see that these are the kinds of data outcomes that are going to drive the future directions. Of course, I've already said we've been undertaking, or the system has been reviewed, and it's not everything works beautifully. Things don't always work as you would like them to. As a result of that, there have already been amendments to the Act, changes to the rules, identification of processes that are not working well enough, and also identification of our workforce development needs, which are ongoing. What does it mean for service providers? So really this has fundamentally changed the landscape of our disability service providers. They now operate in a competitive market. There's an explosion of private practices and sort of a resetting of how things work. Alongside with the individualised, personalised funding for purchasing supports and services for people with disability, funding has also been put into capacity building in other ways as well, though. So there are some other development opportunities across the country. So in summary, I would say that the National Disability Insurance Scheme's purpose and aspirations are definitely participation. It's massive social policy reform, rapid development of complex systems, a complete shift in how services are provided. There is individual choice and control. It's complicated, but the goal is that people are living a good life, that is a participatory good life. And there are bumps on the road, and we keep refining. So I'd just like to finish with a welcome to the conference next year. Thank you.
Thank you very much, Christine, for introducing us the NDIS. Now I would like to welcome our last speaker, Julia Haynes. So please start whenever you are ready.
Perfect. So thank you so much for that introduction, Dana. As a para-athlete and a healthcare provider, I've seen firsthand the benefits of participation, particularly in parasport, and the role that this can play for children, young people, and their families. So I'll use my lens of lived experience as well as some of the research literature to outline some steps moving forward and some of the benefits. So I lived most of my life as an able-bodied person. I was a busy-bodied, active teenager. I did normal teenager things. I worked, I went to school, and I participated in as many sports that I could get my hands on. Unfortunately, at 17, I had a vertebral artery dissection and was left with brainstem ischemia and several complications as a result. I spent what I now know to be a long time in very expensive stroke rehabilitation, building up on very basic physical skills. As you can see from my whiteboard, I spent often 2 times a day in physical therapy, occupational therapy, and speech and language pathology, focused on getting me better. I cannot tell you how many times a goniometer was pulled out to see how much my arm could stretch out. And though I'm very grateful for the services that I received, I know now that they were focused very much on body structure and function and very basic activities of daily living. After a point, I started to realize that I was plateauing. I was no longer reaching my therapy goals, and physical therapy and occupational therapy became exhausting, emotionally, physically, and mentally. I started to internalize this feeling of failure when I wasn't achieving their definitions of normal, and my hemiplegia and physical deficits were persistent. Flash forward 8 years, and I still have hemiplegia. I still live with spasticity, but I'm completely independent. I'm a doctor, and I have had the opportunity to represent my country on the international stage. And despite all of the challenges, I've learned to be happy with my life and with my body as a physically disabled person. This was mediated in huge part through my participation in parasports, and that's what I'd like to share with you today. I think that there's a huge role for early participation-based intervention, specifically parasport involvement, and I'll walk through some of the benefits beyond just the participation domain of the ICF. So we'll start with body structure and function. There's emerging evidence that participation-based interventions can improve body functions, largely through increased physical activity. When we think about weight management, long-term cardiovascular health for our patients with disabilities, particularly those with more involved physical impairments, parasport offers opportunities that they don't get in school at recess, in gym class, and in general outside in their community. It helps them keep active. As well, there's some emerging evidence from Dana's work that shows us that participation, when we can help facilitate community-driven participation for youth with disabilities, we can improve things like cognitive and physical function. I myself have experienced this. Through the design and creation of a sport-specific orthoses seen in the middle here, I was able to use my upper extremity to push myself in sledge hockey, gaining shoulder, back, and core strength that I wouldn't have had or wouldn't have used regularly otherwise. Activities in the ICF refers to the execution of a task by an individual, often in the context of ADLs. We teach so many skills in rehab, but there are many functional skills that get missed in our short therapy windows or very short rehab stays. Parasports offers a peer group and mentors who have perfected these skills over time. Several qualitative studies from the wheelchair rugby community emphasize that improved independence and confidence and safety transferring, doing particularly difficult transfers, as well as improved independent travel. Wheelchair sports also demonstrate improved self-efficacy and wheeled mobility, something I have taken away from my participation in wheelchair rugby and wheelchair basketball. Participation. So this is kind of what we're talking about today, but parasports in and of themselves are a way to facilitate participation in society, which is in line with the UN Convention on the Rights of People with Disabilities goals. Inclusive recreation opportunities, including at school and gym class, at school-based physical activities, at events outside of school for youth and young people have been life-changing. For me, participation in wheelchair basketball at Med Games, an international conference for sport in medicine every year, has facilitated my participation with my able-bodied peers. I know for a lot of the young girls I mentor that their favorite day in school is when wheelchair basketball comes in and they get to shine in gym class for the first time. Beyond this, it helps families participate together on a level playing field. Teams of siblings, cousins, parents, kids all get to participate together, which is something so rarely offered to our families with disability in the community. The Paralympic movement has undeniably changed the environment that we lived in, from changing hearts, minds, but also the physical legacy of having Paralympic Games, particularly in previously inaccessible environments. It can also do this on an individual level around the world, changing awkward and often ableist daily conversations about what's wrong with you and why do you use a wheelchair and why do you walk like that, to conversations about strengths and function and representing your country. It provides access to adaptive recreation equipment like the active hand seen here, like my tricycle that allows me to go all over my city, and like my sledge that allows me to do my favorite Canadian pastime of skating on ice rinks all around Canada. My friend Christina, who has congenital limb deformities, posted this, and with her permission, I'll share it with you. She is an amazing sledge hockey athlete who recently transitioned to Paranordic and was provided a mountain board pictured here to facilitate training in the summer months. She says, these two pieces of equipment, her mountain board and her sea leg, have changed my perception of what I can and cannot do. If I can't walk a path, I can ride it. She goes on to say, I think of all of the years I could have been going on hikes with friends and family if only I knew what was out there. Parasport participation and the access to adaptive recreation equipment is truly life-changing. And finally, personal factors. These are the things that shape how people view their lives as people with disabilities. Growing up and transitioning to life with disability bring exceptional and extraordinary challenges, and having parasports can really change how you look at these. Parasports for me was the first time in a year after my stroke that I felt comfortable and confident. It was the first time that I didn't feel trapped in my body and I felt free. It has given me an acceptance of my disability, has helped me form positive identity around my disability, and has provided improved sense of community, self-advocacy skills, and some of the best friends I could have asked for. Beyond this, and beyond just me, it improves the quality of life for people who participate in it, a goal that we all desire for our kids and their families. So when Dana asked me to give this presentation, I knew that I wanted to talk specifically about participation and improving participation-driven rehabilitation. And what I want to get across to you today is that parasports are not just for people who identify as sporty. They are for all people with disabilities and should be used as an effective, cost-effective rehabilitation tool for all of our kids and families, because the evidence of their reach is so broad and improves participation, function, and quality of life. Thank you.
Thank you so much, Julia, for sharing your personal experience and some insights about the impact of participation, making us really rethink the focus of our practice. And how we provide services to our clients and the families that we work with. I encourage the audience to share some questions, and if they could, if the question is for a specific speaker, please put the name of the speaker. I would like to start, if you don't mind, approaching the three speakers that we have and try to see what do you think we could do in order to reshift practice toward services that are more inclusive, of course, are more accessible, and like Julia was saying, cost-effective as well, right? That we're actually gaining many, many benefits from one single intervention, for example. So I would like to ask you, and you can approach it in the macro level, and the macro level, and the micro level as well, or in the meso level, to really start to share with us some ideas. What actions or what are the first steps that we need to do to make this kind of shift?
Jim, I'll start.
Okay, please.
Thanks, Dana. I think, if the we in that question is service providers, I think it's actually about partnering, and I think it's reaching out to, from wherever your service operates, reaching out to the communities that your services is situated, the community your service is situated in, and partnering across sectors to actually be able to share expertise. I mean, I think Julia's presentation was so beautiful and so articulate in terms of where the expertise is sitting in terms of participation, and therefore how you can garner the learned expertise of those people that you join the sports and activities with, as well as the coaches and trainers within that setting, and then also the therapy expertise that might be nuanced around some of the opportunities that could support people with complexity. So I think the first step to do is to find your best partners.
Thank you, Christine. Any ideas from the others?
So I've got two ideas and then a question for Julia. So for me, I think the healthcare providers needs to be integrated, the importance of disability right from the beginning of their training. So I'm quite passionate that this should be in medical curriculum, so that the full range of medical healthcare providers know about disability, have the skills to meet the needs of people with disabilities, and understand how it's a non-negotiable. So for me, that's very important. And the second is that we need more evidence. So without evidence about what the needs are and what works to fulfill those needs, it's all of us just speaking into the wind, and we'll be shouting against other people, shouting about what's important for them. And unless we can show that things are important and effective and cost effective, it's not going to work. But I was also interested, Julia, that you said you were a doctor, and then as a doctor with disabilities, is that something that you think also influences your colleagues potentially to be more sensitive and effective healthcare providers to people with disabilities?
Yeah, I'm happy to answer both of those questions. Please interrupt me if I go on a bit of a tangent, but I think one thing that we can do that's very simple right now is to, when we meet people with disabilities, is offering them participation in the community in something that is meaningful to them. And it's often hard as a person with a disability when someone says, well, what do you want to do? Then you have no idea what is even out there, what the options are, and you can't envision yourself. I remember Christine giving an example of going to a club in a reasonable way with someone who's your age, right? If you can't envision yourself as those things, you don't even know to ask for it. So I think offering to young people and their families things that are possible and re-offering over time. So if they've rejected it, last year, it may be worth offering again and again and again, so that they know those options are available and they're not shamed or afraid to seek those services. In terms of Hannah's question, I definitely think that, and I don't have the evidence to prove this, so this is all anecdotal, but I do think that my peers are better at identifying environmental and physical barriers as well as attitudinal barriers as a